Good morning, afternoon or evening, depending wherever or whenever you are watching this. This is Amanda Walker and I'm here to talk to you about symptom control and palliative care principles. And so today we're going to do a brief revision of the principles of symptom management and a bit about nausea and vomiting. If you want this information in greater depth, there is a lecture that we did in Year 2, just before the OSCE, that you can refer to. Then we'll also talk about pain, dyspnea, constipation, and caring for the dying patient. So just a reminder about symptom pathophysiology. So the best symptom management depends on treating the cause of the symptom. And I know that sounds a bit basic, but it's actually really important. A lot of people will just try and treat cancer pain, but they won't contemplate how the cancer is causing the pain. And the way the cancer is causing the pain makes all the difference. And in line with that, the symptom pattern that a patient experiences depends on where the disease is located and what the cancer is impacting on. And that's why the staging and clinical information is so important, because you need to understand whether the information you already have explains the symptom that the patient is experiencing, or do you need to actually investigate further to confirm that the cancer is spread and to identify the cause so you can attempt to treat it. Now, the goal, wherever possible, is to rule out or treat whatever is reversible. And what you cannot reverse, you then palliate. And the general principles of drug use, you need to understand the mechanism of the symptom and the action of the drug. So it comes back to that, understanding the mechanism of the symptom. The other thing is that persistent or recurrent symptoms require regular medications, not just PRN. PRN technically stands for pro res necessitas or pro re nata, which means as the thing requires. But in real life, it probably stands for patient receives nothing or pain relief never. And that's because you're waiting until someone's in pain or experiencing a distressing symptom before you give them something. And if you know that the tumour is going to be causing the pain continuously, it's pretty cruel and probably a bit unethical to leave someone actually just experiencing the pain before you bother to give them something. Having said that, you always give regular plus PRN in case they need a touch more. So nausea and vomiting, as I said, we covered this in second year, but I just wanted to quickly revise the principles of antiemetic choice, which comes back to identifying what you think is the cause of nausea and vomiting in the patient, identifying the pathway by which each cause triggers the vomiting reflex, identifying the neurotransmitter involved in the pathway, choosing the most potent antagonist to the neurotransmitter receptor identified, and if several mechanisms are involved, using the most potent for each, rather than one with weak actions against many. So you go for the strongest one, not the scattergun approach. Choose the route of administration which will ensure the drug reaches the target site, and this may exclude oral. Titrate the dose regularly, and review the patient regularly and give them antiemetic regularly. If symptoms persist, you need to consider another cause. And sometimes causes can change in the course of time. So, just a reminder, there's 4 different ways you can activate the vomiting centre. So the gut, the cerebral cortex, the chemoreceptor trigger zone, and the vestibular system. And they all activate the vomiting centre, which coordinates the process of vomiting. So there are 5 questions you need to ask. Is it worse with the sight or smell of food? In this case, it's central nausea. Is it worse with eating food? Most likely to be gut nausea. Is it worse in the morning with other signs of increased intracranial pressure? For example, headache or other cranial nerve signs. So that's classically an increased intracranial pressure, kind of nausea and vomiting. Is it worse with movement, which means it's most likely cranial nerve 8? And does it build up until you vomit and then get better after you vomited, which is likely to be from the gut? Or you just keep retching and keep vomiting and vomiting and vomiting until you've got nothing left to vomit. And that's central nausea. So again, if you want to go into that in more depth, go back to second year. So Once you've determined which of these 4 centres are activating the vomiting centre, then you need to work out what's the most powerful neurotransmitter. And this is where we look at things like metoclopramide is actually a mild dopamine antagonist, but haloperidol is a strong dopamine antagonist. In terms of antihistamines, cyclizine is a really strong one. And then in terms of muscarinic antagonists, hyoscine hydrobromide is the strongest. 5-HT3 antagonists, well, ondansetron, tropisotron, all of them are clearly the strongest ones. In really high doses, metoclopramide is actually a 5-HT3 antagonist. And 5-HT4 antagonists, well, cisapride is the strongest one, but it can actually prolong a QT interval. So we tend to use metoclopramide as the primary agent. Cisapride is only available in the special access scheme. And this, again, is just another way of looking at the same issue. So if the cause is drugs or metabolic-related nausea and vomiting that's activating the chemoreceptor trigger zone, then dopamine and 5-HT3 antagonists are effective. If it's due to motion and position, the vestibular system is the cause, and therefore antimuscarinic and antihistaminergic agents. If it's from the viscera, so the abdominal organs, then dopamine and 5-HT4 agonists. And if increased intracranial pressure, it's through the cortex, and antihistamines are effective. But we also use dexamethasone to try and decrease the swelling around a tumour. And all of these agents work on the vomiting centre, which then coordinates the process to the effector organs and hopefully slows down the vomiting reflex. So there's a big sign with a bar through the 5-HT3 antagonist, because I just want to remind you, as you go out to practice, you will see so many people who reach for ondansetron and tropisotron as first-line antiemetics because they assume that because they work for chemotherapy, nausea and vomiting, they must be the strongest ones and they must be the best, and they'll use them for any kind of nausea and vomiting. And the problem is that they're really good at what they do for nausea and vomiting, for chemotherapy and anesthesia and radiotherapy, but they make people constipated. And if someone is nauseated and vomiting because they've got a bowel obstruction, this will make it worse. Okay? And you need to be really careful when you choose to use them. Okay? So please don't reach first for your 5-HT3 antagonists. Reach first for the appropriate drug. You guys know this better. So on the ward, I just want to remind you to watch how antiemetics are prescribed and adjusted. And if you have any questions or concerns, go back to the Year 2 lecture. So on to pain. Again, some general principles. Believe and acknowledge the complaint of pain. And I cannot underemphasize. Empathy, explanation and reassurance have a profound pain-relieving effect. I am astounded how often when a patient comes in to be admitted and they're in significant distress with a lot of pain, and you sit down and you take their history and you listen to what is disturbing them, before I've even gotten out my pen to chart the analgesic, before the nurse has gone to the cupboard to get the analgesic, they're already starting to feel better because they feel like someone has heard them and that someone is going to do something about it. And just relieving that anxiety can make a huge difference. Remember, noradrenaline and adrenaline are pain neurotransmitters, and easing someone's anxiety can make a huge difference. Always use the minimum dose required to relieve the symptom, and side effects should be anticipated and prevented wherever possible. Simplicity is the essence, so always use the oral route wherever possible, unless the patient is not able to tolerate oral analgesics. If you hear purring, this is now my cat sitting on my lap. So say hello, Tenzing, to the lectured students. Hello, purr. Okay. So simplicity is the essence, and the oral route is preferable where possible. In order to prescribe opioids safely and appropriately, you need to understand that there are new formulations of opioids. So immediate release and sustained release. You also need to know that there's a whole series of new opioids actually available, and you need to understand the differences between those newly available opioids. And you need to be aware of the conversions between them. So you need to know that hydromorphone is 5 times as strong as morphine. You need to be able to write accurate and valid opioid scripts, and you need to be able to seek assistance when required. That's probably the most important thing, to know your limits. So, the approach to pain management. I just want to point out a little 5-step approach. The first is, where possible, decrease the noxious stimulus with local treatments. So if something is inflamed, ease the inflammation. Improve threshold issues, and by threshold issues I mean the things that are making people distressed and anxious. And this is where cortical override can make a powerful impact. So listening to someone, addressing their anxiety, their depression, their distress. Exploit the opioid receptor system. We have a God-given or evolutionarily derived, whatever you believe, opioid receptor system, which means that we have a built-in system which actually decreases the amount of pain we experience. Pain is supposed to be an early warning system, an alarm. It shouldn't be prolonged. So you actually need to activate the opioid receptor system to decrease the experience of pain in the spinal cord and the cortex. And then you need to recognise and manage the really tricky kinds of pain, like neuropathic pain, which are unusual and slightly different. And you need to do this by enhancing descending inhibition, and I'll explain what that is in a moment. And the final thing is return and review the patient. Again, we covered this in second year, but it's important revision. So in terms of what you're actually doing with these 5 points. So in terms of local therapies, heat packs, massage, TENS, acupuncture, anything that decreases the local perception of pain. There are some recent studies which suggest that acupuncture is probably not effective. Then consider threshold issues, anxiety, depression, other stresses in life. And if you have advanced cancer, chances are you'll have a few other stresses in your life. And it's worth trying to get to the bottom of them. And if you're not the right person to do that, then get a social worker or a counsellor, someone who is. Then exploit opioid receptors. So using the medications regularly, plus PRN. Oral if possible, and always anticipating side effects, like constipation, the possibility of nausea and vomiting, etc. Adjuvant therapies. So for neuropathic pain, you need to bring in the extra things. For bone pain, you need to bring in other extra things. So for example, for neuropathic pain, tricyclics, anticonvulsants. For bone pain, bisphosphonates. And then return and review. And partly because this is probably the best time. When you have sorted out someone's pain, they are so grateful. It's such a powerful stimulant. I ended up doing palliative care. But if it hasn't worked, it's really important to then consider, do you need to titrate upwards, or do you need to escalate and get someone who knows what they're doing to consider something like opioid rotation? So we don't expect you to do opioid rotation. We expect you to notify us that what you're doing is not working. So here are the nociceptive pathways, and I just wanted to remind you about the concept of descending inhibition. So you've got pain transmitted from A delta and C fibres in the periphery, and it goes along, and then it actually is transmitted at synapses in the dorsal horn of the spinal cord. Now this is where there's actually some strong opioid activity, and so if the message comes in from the periphery along those A delta and C fibres, and then it gets to the dorsal horn, and if you're taking opioids, you perceive the pain at the periphery, but once it gets to the spinal cord, the message is not transmitted. It's an inhibitory activator, and so the message is not transmitted to the spinothalamic tract, which decussates and heads up to the brain. And so basically the brain is saying, and you can't see me actually plug my fingers in my ears as I do this, but not listening, not listening, not listening. And it's just ignoring the messages, and the messages stop going through to the brain. The other place where opioids actually act is in the midbrain. in the periaqueductal grey and the dorsal raphe nucleus. And it's enhancing what's called descending inhibition. And that, again, is the brain saying, not listening, not listening, not listening, because descending inhibition is actually a pathway which increases inhibition at that same synaptic level. Okay? So again, you've got this nice little loop which is actually shutting off the message, don't want to hear it, not interested. And it's the same thing that happens if you, for example, have a runner's high. Personally, I'm not very familiar with them. But if you have endogenous opioids, they activate descending inhibition and you no longer get the messages from your tired, painful legs that running this marathon is hurting me, and it's actually stopping the transmission of the painful impulses back to the brain. And when you're looking at things like tricyclics, they're actually increasing the descending inhibition pathway. Anticonvulsants or neuromodulators are decreasing the transmission along any of the nerves. So, opioids. These are some beautiful Tasmanian poppy farms. We have Australia is the world's leading producer of medicinal grade opioids, and these are beautiful Tasmanian poppy fields, and you can see the fields are carefully ringed. They're actually ringed by electric fences to keep the cows out, which has led to the hilarious headline in the Hobart Mercury, "Stoned wallabies making crop circles," because wallabies were able to jump over the electric fences and then they would eat the poppy hips and they would be affected by the opioids. Now, there are lots of opioids out there. These are just solid, so not liquid or injectable, but solid oral morphine and oxycodone products. So there's a whole bunch of different options, and you can see that there's immediate release tablets, there's sustained release tablets, and sustained release capsules by different companies, and the same for oxycodone. And when I was a medical student, there was oral morphine and there was injectable morphine. None of these slow release tablets existed. And you'll find that a lot of your consultants are not actually that familiar with all the different options out there. And this is one company's options. So this is one company, Mundipharma, which makes MS Contin and OxyContin and Dilaudid. But they are by no means the only analgesic company. And you'll realise very quickly that the logic of the names changes between companies. So this company uses Contin to designate that it's a sustained release product, but the makers of Tramadol call Tramal is the immediate release form and Tramal SR is a sustained release form. So you need to get familiar either with the products or with looking up MIMS to check whether the product is short-acting or long-acting. And if it says it lasts 4 hours, it's immediate release. If it says it lasts 12 hours, it's sustained release. So just do a quick run through of all these different ones. OxyContin, sustained release. Audin 2 is immediate release morphine syrup. Duragesic is the ultimate sustained release delivery system. That's the analgesic patches. Oxynorm capsules are immediate release. Morphine sulfate is morphine for injection. Kapanol is sustained release. And it's actually a little capsule filled with granules, and you can actually break open the capsule and sprinkle it on yogurt or ice cream if people have swallowing difficulties. Tramal is immediate release tramadol. Physeptone is the company's brand name for methadone. Dilaudid injections are immediate release injections. Sevrodol is immediate release. Rapidine obviously is immediate release. MS Contin is sustained release. Jonista is sustained release hydromorphone. Endone is immediate release. Tramal SR is sustained release tramadol. Panadine Forte is immediate release. It's codeine with paracetamol, and it's 30 milligrams of codeine, whereas Panadine and Rapidine are 8 milligrams. Audin 5 is Audin 5 milligrams per mil. Interestingly, Oxynorm 5 is Oxynorm 5 milligrams per 5 mils. MS Mono is daily morphine. Morphine tartrate is morphine for injection, and Oxynorm liquid is immediate release oxycodone. So with this slide, you can see that if you wait until someone is in pain to give them pain relief, a la PRN, then you're actually leaving them in pain for a period of time before you're actually giving them analgesia. So the goal is to actually give it every 4 hours so that you're actually keeping them within the appropriate dosing range with adequate analgesia, but without toxicity or suboptimal subtherapeutic analgesia. Once you've got them steady, then you change them over to sustained release here so that you have this nice smooth curve, but they're well within the range and they're always having enough analgesia but not too much. So the importance of the different formulations: immediate release is for rapid titration and effective breakthrough medication. Sustained release is for sustained pain control with convenience and compliance. So opioid conversions and analgesic equivalents. If I had you here in person, I would play the new dose is right, and I would ask you to arrange, and I'd like you to do this in your head right now, to arrange these drugs in order of strongest to weakest, okay? And I could turn everything off for a moment and do that, but I won't. I'll just let you stop the machine and stop the recording and actually just think that through in your head. Because here is the answer. Fentanyl is the strongest. It's measured in micrograms. That's the giveaway. It's 100 times stronger than morphine. Then hydromorphone is 5 times stronger than morphine. Oxycodone is 1.5 times stronger than morphine. Morphine is the same, obviously. Tramadol is 1/5 the strength of morphine, and codeine is about 1/6 to 1/7. So on the ward, I want you to watch how medications are adjusted up and down, watch how analgesics are converted from oral to subcutaneous, and vice versa, and then watch how immediate release is changed over to sustained release, and how they do the conversions between different drugs. Constipation. This goes hand in hand. So the side effects of treatment should be anticipated and prevented wherever possible. I keep saying this. We know that currently all opioids constipate, and particularly when you start them. So you need to get your head around bowels, okay? And there's a few traps as well. So you need to be aware of cumulative effect with opioids and adjuvant analgesics. So for example, tricyclic antidepressants will constipate on top of the opioid constipation. So those patients need extra laxatives. You also need to know to beware a loss of analgesic efficacy due to poor drug absorption, secondary to fecal impaction. So if someone gets fecally impacted, they won't absorb the sustained release opioid, and therefore they'll lose some of their pain control. So please, please, please don't forget your laxatives. The Canadian Palliative Care Curriculum says the hand that writes the analgesic order must also write the laxative order. In terms of aperients, there are lots of different options. Plain Caloxyl is a softener, Caloxyl with Senna is a stimulant, Senecot is a stimulant, paraffin and agarol is a lubricant, Movicol is a non-osmotic softener, and lactulose is a dehydrating osmotic. So lactulose and sorbitol we don't tend to use that much in palliative care because they actually require large volumes of water to be effective, and often our patients are struggling to actually keep up with their fluid intake. And they can actually dehydrate people, and they have actually been known to drop people's blood pressure. So on the ward, watch how bowels are managed and review abdominal x-rays when you're looking for constipation and fecal impaction. Dyspnea. So, in terms of physiology, we are more like dogs than we like to think. You know how dogs like to stick their heads out windows and feel the movement of air on the tip of their nose? We are just the same. The flow of air is beneficial due to the activation of inhibitory nerve fibres from facial receptors, especially at the tip of the nose. So this is where the role of a fan, nasal prongs and open windows comes in. The interesting thing is oxygen versus compressed air. For most patients, there's no difference in symptom improvement. So just having the movement of air makes all the difference. In terms of physiology, the sensation of dyspnea is due to the need for excessive respiratory muscle action. If I have to work hard to breathe, I will feel short of breath. And that's transmitted by increasing discharge of impulses from the motor to the sensory cortex. Now think about most reflexes. They go from the sensory to the motor system. So this is called corollary discharge, meaning it's going the other way. And it activates multiple pathways, causing panic. And the interesting thing is that opioids diminish the perception of distress from dyspnea, just like they do for pain. So in the same way the brain says, not listening, not listening, not listening, with my hands plugging my ears, which you can't see, it does exactly the same thing for dyspnea. A lot of people assume that opioids will depress respiration at the respiratory centre in the medulla and therefore use them. But we shouldn't be giving opioids to slow respiration, because then we're actually giving it to the point where people are already drowsy, sedated, toxic and twitchy before they get to this point of respiratory depression. So in terms of managing dyspnea, you need to establish and treat the cause. You need to treat hypoxia with oxygen and treat the symptom and sensation of distress of dyspnea with opioids. Then you can consider the impact of anxiety and panic and increased oxygen consumption. And that's where relaxation techniques can make a huge difference to people. Even just distraction, listening to music can make a difference. Some people find a nebulizer is quite comforting in terms of their anxiety and can make a difference. And you may consider anxiolytics if someone's actually having panic attacks. Physiotherapy to clear sputum can be really helpful if that's a problem. But the most important thing is having an action plan to support and educate carers about what to do. Because if you're watching someone be short of breath, it's profoundly distressing. Opioids for dyspnea constipate just as much as opioids used for pain, because they're still opioids. And I've said it so many times that now my cat is going to say it. The hand that charts the opioid must also chart the laxative. And on to the dying patient. The aim of care of the dying is to make the patient as comfortable as possible so he may be free to prepare for death as he wishes. In terms of symptom control, you again need to come back to what is the pathophysiology of the symptoms. If someone is restless and agitated, you need to consider, are they constipated? Are they in urinary retention? Are they emotionally distressed? Are they delirious? What's actually causing this? So you need to get to the basis of the pathophysiology of symptoms. So as always, you establish the etiology and you aim to treat the cause and the mechanism of the symptom. In terms of medications, you need to take into account that there are swallowing issues. So you may need to cease or rationalise medications. So you're no longer aiming to treat someone's blood pressure for long-term prevention, so they can stop their antihypertensives. In terms of blood glucose control, you may actually be prepared to tolerate a blood sugar between 5 and 20. And so you just need to consider what is most important for this patient at this point in time. In terms of end-of-life symptom control, pain is clearly a problem, and you need to know your analgesic conversions and be able to halve the dose to actually give the subcutaneous dose. There are different ways to consider changing from old to subcut, and in some places they use a 3-to-1 subcutaneous conversion ratio because they feel that is the most conservative and therefore the safest. In New South Wales we tend to use a half dosing, but you will see in some textbooks that some people use 1-to-3. Restlessness. If people are restless or agitated, you need to know how to manage it. And then rattly breathing. As people get sick, they lose the strength to swallow, and saliva and secretions pool in the back of the throat and can make a really horrible rattling sound, which is distressing for the people watching the patient. We don't believe it's distressing for the patient themselves. And often just turning the patient can make a big difference and help some of this fluid drain away. But you can use anti-muscarinics like hyoscine hydrobromide to actually decrease the saliva production, but then you need to make sure you keep the mouth moist. So when you're reviewing the medications, you actually cancel unnecessary meds and change the oral meds. You change the route for analgesics, antiemetics, and the important medications you want to continue, like, for example, anticonvulsants. Then prescription of terminal care PRN meds. Now, sometimes you'll see these written as terminal crisis meds or terminal catastrophe meds. Truly, a terminal catastrophe is when there's an emergency that requires a large dose of a sedating medication, but most of the time in the med charts, people will call them crisis meds just so that families aren't distressed if they happen to flip through the medication charts. So antisecretory medications, breakthrough analgesia, anxiolytics and antiemetics. And you need to anticipate possible terminal events. For example, terminal catastrophes, like if someone has a massive hemorrhage, for example, a head and neck tumour eroding into the carotid artery. And you need to have the appropriate PRN meds available. Now, prognosticating is hard, and it would be easier if there were ward vultures that told us when time was getting short. And there is actually a cat called Oscar the cat in a nursing home in the US who, when he sits on the bed, chances are the person will die within 24 hours. And it would be so much easier if we were able to prognosticate really well. We're not very good at this. But interestingly, there's another area of medicine that we can draw on. So the estimated date of confinement in obstetrics, how many people are born on the day that they're due? And in fact, what doctors do is they say, we'll know when things are starting to change, when you start having contractions, when your waters break, that kind of thing. And what we need to start talking with people about is the sign that things are starting to change and actually giving them the power to understand. So when people are spending more time in the chair, more time in the bed, more time asleep in the bed, when they struggle to actually get out of bed to go to the bathroom, these are the physical changes that we know that time is getting short. Eventually they'll drift into what looks like a sleep, but they'll still move their eyes, squeeze your hand when you talk to them, that kind of thing. And so we see those functional status changes. We see changes in appetite and intake, changes in responsiveness, a few words diminishing to just a word, a sound. Then changes in breathing patterns, for example, Cheyne-Stokes respiration. Rattly breathing, then circulatory changes, and pain and restlessness can be seen and addressed. Watch a palliative care physician prepare a family for death. What do they say and how do they say it? So you can see on this graph, most patients slowly deteriorate, but then their functional status starts to change dramatically and they deteriorate very quickly. In the second graph, you can see patients with COPD and congestive cardiac failure have these episodes of deterioration, but they bounce back from them eventually, until at some point in the middle of one of them, they continue to deteriorate. And then there's the prolonged dwindling of dementia. In terms of terminal medications, we've spoken about morphine. You can change it to subcut. You can give it via syringe driver if possible. That's just easier for administrative purposes, with a 2-to-1 conversion ratio. Clonazepam for terminal agitation and hyoscine for rattly breathing. So on the ward, watch what terminal care PRN meds are charted, and also watch the discussions that your palliative care specialists have. I want to remind you, in spite of our vast knowledge and our superior technology, there are times when all of us in medicine become the treatment, when what we most have to offer is ourselves. So on the ward, don't be afraid to get to know patients, but do be prepared to face your emotions when you do. If you need to talk to a staff member about how that makes you feel, don't be afraid to. You will be supported. You will never be laughed at for being distressed. Okay? If you need to call, you can speak to me. My number is 0408 435 015. Please don't give it to the chlamydia hotline as someone did a few years ago. But the last thing I want to say to you is I wish you good courage. So the French have a lovely expression, bon courage. It's not just good luck, it's I wish you good courage. Facing patients who are dying is not necessarily easy, but it is profoundly satisfying. And I hope that some of you will actually find in the course of this term that you realise you're good at this and that you might actually consider this as a career. So I wish you good courage, partly because I know that you will be of benefit to the patients that you spend your time with. Please remember, just being a human alongside a human being can be the most therapeutic intervention that you can actually possibly give. And as a medical student, you may think, I have no power, but actually you do. So I wish you good courage, and you're free to contact me if you need to. Thanks.